Good morning students. Today we are going to start development of urinary system. So in this class you are going to learn development of pronephros, mesonephros and metanephros. That means the development of the urinary system includes a sequential development of these three system of kidneys. That means pronephros we see some of the fishes and mesonephros. So these are the phylogenetically in the older animals. So and the adult, the humans in the mammals, this is the metanephros which develops and gives rise to the adult kidneys, right? So these will be in the early stages of the development of the embryo. We don't see any remnants of the pronephros and we see the remnants of mesonephros. Not exactly the mesonephros, but the duct of the mesonephros will be developed and it will give rise to the development of male genital system, and then formation of the mesonephric duct and derivatives of the mesonephric duct both in the males as well as in the females. So what it is going to give rise to, the mesonephric duct is going to give rise to in both males and the females. Then formation of the ureteric bud, and so where from this ureteric bud forms and what are all the derivatives of the ureteric bud. And then finally it is the metanephros which gives rise to the adult kidney, the permanent kidney. So where this metanephros develops and what are all its positional changes and how it attains the adult position and shape. Then we discuss the formation of the urinary bladder. And then we also discuss in this class the developmental abnormalities of the urinary system. So in relation to the developmental abnormalities of the kidneys as well as the urinary bladder. So first we'll see these pronephros. So what are these pronephros? So these are the primitive excretory system which is developed in the cervical region. So this will be in the cervical and in the upper thoracic region. So this is the segmental development. So this mesonephron, this pronephros, so will be having a unsegmented part of mesoderm which is present in the cervical region, and in that, so on either side of the midline, so this pronephric ridge. So this will gives rise to the, so this is the primitive pronephros, so which has an excretory units. So where this will be having the glomerulus, so and this will be draining so into the coelomic cavity. So the excretory products of these pronephros will be going into the coelomic cavity through the external glomerulus, and their collecting system is not much developed in the pronephros. But we don't see any remnants of the pronephros in human beings. But only in the fourth week of intrauterine life we see the pronephros. Then coming to the mesonephros. So this is in the cervical region where you see the pronephros. As the caudal ones, the pronephric tubules appear, the cranial ones will disappear, and finally this pronephric tube duct also will disappear. We don't see any remnants of this. So maybe probably this may gives rise to the line where the mesoderm, where it differentiates into the genital system. So except for that, there is no role for the pronephros in human beings. Then the next one is the mesonephric ridge. So this is the mesonephros where it forms in the mesonephric ridge. So on either side of the midline, the intermediate mesoderm is thickened and forms. So this is the unsegmented intermediate mesoderm which will give rise to the mesonephric ridge. And this mesonephros so consists of mesonephric tubules. So these are the mesonephric tubules, and these mesonephric tubules will be draining into the mesonephric duct. So all these mesonephric tubules, they will join and forms a duct. So this duct is also called the mesonephric duct or the Wolffian duct. So Wolffian duct and the mesonephric duct are the same. So these will be on either side of the midline. And this mesonephric duct will be draining into the, so will be opening into the primitive cloaca. So here this primitive cloaca is divided. So the caudal part of the developing gut here. So this is divided into, so the caudalmost one is undivided, but the cranial part of this hindgut will be divided into a ventral part, the urogenital sinus, and a dorsal part, the primitive rectum. So this we discussed in the previous class with the formation of the urorectal septum. So this part forms the urorectal septum. So this urorectal septum divides this hindgut, the lower part of the hindgut, into an anterior part, the urogenital sinus, and a posterior part, the primitive rectum. So this urogenital septum further descends down and divides completely this cloaca into a ventral part and a dorsal part. So the endodermal cloaca here is divided. So that part we will see later. So for time being, just remember, so ventral part of this hindgut, so will form the urogenital sinus. So this mesonephric duct opens into the urogenital sinus. So it will be opening into the urogenital sinus. So when these mesonephros will be functional, so this will be in around the 4th and 5th weeks of the intrauterine life. So very early we see these mesonephric ducts. As the caudal mesonephric ducts appear, the cranial ones will disappear. So where these mesonephric ducts are formed? So these are formed in the thoracic and the lumbar region. So the thoracic and the lumbar regions we see the mesonephric ridge, and these mesonephric ridge so consists of, there you see the mesonephros and the mesonephric tubules, and these mesonephric tubules will be draining into the mesonephric duct, and this mesonephric duct is also called the Wolffian duct. So here, so this is the structure of the mesonephric tubule, and for any excretory part, whether it is the mesonephros, pronephros, or the metanephros, there will be a collecting part, excretory part here, so and a collecting part. So this is the excretory part where you see the formation of the excretory tubule, of that is the Bowman's capsule like structure, and the glomerulus. So glomerulus is nothing but the tuft of capillaries. So with this is forming like a cup-like structure, and into which you see the glomerulus, and here the filtration occurs, and this filtrated fluid will be going through the mesonephric tubule, and finally this mesonephric tubule will be going into the mesonephric duct. So you see series of mesonephric tubules like this. So you see the series of mesonephric tubules, and all these mesonephric tubules will be, so this is the series of mesonephric tubules. Like this you see the mesonephric tubules continuation, and all these mesonephric tubules are draining into the mesonephric duct. So this is the glomerulus part of, so this is the mesonephros and the collecting part. So if you see it like this will be, so here will be the capillaries, and these will form the mesonephric tubules. This is the mesonephros, and this is the mesonephric duct. So all these tubules will be draining into the mesonephric duct, and finally this mesonephric duct, where it is going, so this is the mesonephric ridge with the mesonephros, and this will be going into the urogenital sinus. So here at the, so where this urorectal septum is coming here and divides this into, so the ventral urogenital sinus and the dorsal primitive rectum. So into this urogenital sinus we see the opening of the mesonephric duct. So this mesonephros also will disappear. So we don't see any remnants of these mesonephros. All these mesonephros will disappear. So there is no role for the mesonephros. But so you may ask me why this mesonephros development is occurring. Because this mesonephros is essential for the development of the and differentiation of the metanephros, as well as the formation of the collecting part of the metanephros. So how it helps in the development of the metanephric reach and then the metanephric collecting system. So we will see now. So here, and also this mesonephric duct. So this mesonephros is important in the development of the mesonephric duct. So this mesonephric duct or the Wolffian duct is going to differentiate into the male reproductive system structures in case of the males. But in case of the females, this mesonephric duct will disappear. So we don't see much remnants of the mesonephric duct in case of the females. But so you should ask why this mesonephros is then developing in the females, because it is giving rise to a part of the excretory system. It is essential for the development of the mesonephric duct in both the males and females. But initially we see the development of the mesonephric duct, but later its development will be suppressed once we see the development of the kidneys in case of the females. But in case of the males, this mesonephric duct will persist in development and it will give rise to the male reproductive system structures. Then this is the mesonephric duct. So where this mesonephric duct is going, it is going into the urogenital sinus. So by this time we see the separation of the urogenital sinus from the primitive rectum, and this mesonephric duct which is going into the urogenital sinus here. So from here the mesonephric duct, so caudal part of the mesonephric duct, where it is going into the urogenital sinus, there we see the development of a small diverticulum, initially a small diverticulum from this mesonephric duct, and this diverticulum is called the ureteric bud or the metanephric bud. So this metanephric bud or the ureteric bud, will elongate, and this will meet the metanephric blastema. So I told you in the same line. So here you see the pronephros in the cervical region, then in the thoracic and the lumbar region you see the mesonephric tissue, and then in the pelvic region, so lower lumbar and the sacral region. So in this region you see this mesoderm, intermediate mesoderm, is differentiated into the metanephric blastema. So this metanephric blastema is the intermediate mesoderm. So into this metanephric blastema we see the growth of this ureteric bud. So this ureteric bud which is developed from the mesonephric duct will elongate and reach the metanephric blastema. So this is called the ureter. So later you will call it as the ureter or metanephric tubule. So metanephric duct, not tubule, metanephric duct, but metanephric duct we are not using, so we call it as the ureteric bud and the ureter. So this, as it reaches the metanephric blastema, so it will form a dilatation in the where it is going to reach this region, and this dilated structure, so this will gives rise to the formation of the renal pelvis, and then it will divide further and further. So first 4 generations of that will be forming, the first 2 generations of this division will form the major calyces, and up to the 4th generation, so these will form further divide, and these will form the minor calyces. So you know the structure of the adult kidney, so which is having the cortex and the medulla where the collecting tubules, so these will form the medulla, the papilla and the pyramids, and these will be at the tips of the pyramids we call the papilla, where you see the collecting ducts. These will be draining into the minor calyces. So these minor calyces will join to form the major calyces, and finally these will be forming the calyceal system, pelvic calyceal system. So and then this will form the pelvis of the kidneys, and then the ureters. So here this ureteric bud, so which is developed from the metanephric duct, will be elongated and reaches the metanephric blastema here. So once it reaches the metanephric blastema, it further divides, and from 5th generation onwards, so these will divide into the small collecting ductules, and further it will divide and reaches the nephron. So you know the structure of the nephron. So the nephron consists of the Bowman's capsule. So it consists of a Bowman's capsule where you see the form. So here you see the tuft of capillaries which is called the renal corpuscle, and then this is the Bowman's capsule where the excretion will be occurring, filtration will be occurring here, and then this will continue with the proximal convoluted tubule. Then you see the formation of the proximal convoluted tubule. Then you see the loop of Henle. Then you see the loop of Henle. Then so this will be elongated, and then you see the distal convoluted tubule. So this has to come here, right? So distal convoluted tubule, and then finally the distal convoluted tubule will be connected to the collecting duct. So these collecting ducts, so collecting tubules, so this will form the collecting tubule, and this collecting tubule will be continuous with the collecting ducts. So that's how you see the formation of the nephron here. So here this metanephric blastema will gives rise to the renal vesicles, and this tissue will be differentiated into the entire part of the nephron till the distal convoluted tubule. So till the distal convoluted tubule we see that is developed from the DCT. So it is developed from the metanephric blastema. So this is the metanephric blastema. So this tissue, this contributes to the mesoderm of the metanephric blastema, will lead to the development of the nephrons till the distal convoluted tubule. And then here after that this collecting duct, and then the collecting tubules and the collecting ducts, these are developed from the ureteric bud. So this ureteric bud, once it comes in contact with the metanephric blastema, so you see number of divisions of this ureteric bud, further it will divide like this. So you see multiple generations of this division of the ureteric bud, and these will give rise to the collecting duct. So you see number of divisions of that, and these finally each one of this duct is capped by the metanephric blastemal tissue. So this is the capped by the metanephric blastemal tissue, this tissue. So this metanephric blastemal tissue will differentiate into the renal vesicle, and this will gives rise to the later it will differentiate into the Bowman's capsule, proximal convoluted tubule, loops of Henle, and then the distal convoluted tubule, and into that you see the mesoderm further differentiates and forms the glomerular tuft, which will go into the renal vesicle here. So this is called the renal corpuscle. So this forms the renal corpuscle, and then so here each of this collecting duct is covered or capped by the metanephric blastema. So once we see the formation of the nephron, the distal convoluted tubule till there, so it will be like a blind ended structure here, and this will be like a blind ended structure, and once these two come in contact with each other, so this part will be erupted, and there will be establishment of communication between the distal convoluted tubule and the collecting ductule here, collecting tubule here. So that you can see the continuity between this renal vesicle and the collecting duct system. So the excretory part and a part of the collecting duct, the collecting system is developed from mainly from the metanephric blastema, and most of the collecting part is developed from the ureteric bud. So the adult kidney, if you see the excretory system, so when you compare this mesonephrians and the pronephros, it is little different from the metanephros. It is totally different. It is developed from two sources. One is the metanephric blastema, other is the ureteric bud. So the collecting part is developed from the ureteric bud, so which is further derived from the mesonephric duct, and then the secretory part or the excretory part is derived from the metanephric blastema. So now we see the what is the fate of this metanephric duct and the tubules here. So here the fate of this metanephric duct so is important, and the tubules. So mostly these metanephric tubules will be vestigial. So there is no role for these metanephric tubules, but except for the efferent ductules of the testis. So in the testis, so if you remember the structure of the testis, the male reproductive system, so you see the seminiferous tubules, then these seminiferous tubules, so these will form the retitestis, and from the retitestis you see the different ductules, and all these efferent ductules will join to form the epididymis. So here these efferent ductules are derived from the mesonephric tubules. So these mesonephric tubules will give rise to the efferent ductules. Only some part of the mesonephric tubules will give rise to the efferent ductules, and then rest of that. So here the proximal tubules. So, and the distal tubules, the proximal and the distal mesonephric tubules will become vestigial, and these will form the ductus aberrant superior and ductus aberrant inferior, or the paradidymis to the which are attached as small appendices to the testis. So usually we don't see these structures. Sometimes you may see to the testis attachment of these extra small duct like structures, and these are called the ductus aberrant superior, ductus aberrant inferior, and the paradidymis. So these are the remnants of the mesonephric tubules in case of the males. And in this is important structure you should remember, that is the efferent ductules. So efferent ductules of the testis are also derived from the mesonephric tubules, and the proximal and distal mesonephric tubules will disappear, and if they persist, these will lead to the ductus aberrant superior and ductus aberrant inferior and the paradidymis. Then the mesonephric duct. So what are the remnants of the mesonephric duct? So all these mesonephric tubules, they join and forms the mesonephric duct. So this mesonephric duct will give rise to the development of the canal of the epididymis, vas deferens, seminal vesicles, and the ejaculatory duct. So you know that in case of the males, this ejaculatory duct is opening into the prostatic part of the urethra, right? So up to here, so the mesonephric duct will give rise to the collecting part of the male reproductive system, that is the canal of the epididymis, vas deferens, seminal vesicles, and the ejaculatory duct. So here the fate of mesonephric duct you should remember, because so this can be asked as a 5 marks question in the university exam. So when it is asked, you should write what is mesonephric duct, what are mesonephric tubules, and what are its remnants in case of the males, females, and in both sexes together. So this you have to remember and form a notes for this. So you know that mesonephric duct is developed from the mesonephros, mesonephric ridge, and then mesonephric tubules, and these mesonephric tubules join to form the mesonephric duct. So what is the other name for mesonephric duct? It is the Wolffian duct. And then, so this mesonephric duct, so will be present on either side of the midline, and finally it is opening into the urogenital sinus. The posterior part of the urogenital sinus traverses through the urorectal septum and then goes into the urogenital sinus. So here the remnants of this mesonephric tubules we just discussed, and the mesonephric duct in case of the males will gives rise to the male reproductive system, the collecting part of the male reproductive system, that is the canal of epididymis, vas deferens, seminal vesicle, and the ejaculatory duct. So in case of the females, so this mesonephric tubules so will give rise to the epophoron and parophoron. So these are totally vestigial tubular structures which are obliterated, and these are present in the broad ligament. So you know broad ligament of the uterus. So uterus on either side, so a fold of peritoneum covering, so will form the broad ligament on either side of the uterus, and these will form the mesonephric tubules and will form remnants as the epophoron and the parophoron. Sometimes this mesonephric duct will totally disappear. There is no role for the mesonephric duct. Sometimes it may persist in the females and forms the duct of epophoron, which is also called the Dog-Gartner's duct. So this Gartner's duct is important because sometimes the collections in the Gartner's duct may lead to the Gartner's cyst. So that is why it is important. So there is no role for the Gartner's duct in case of the females, and the mesonephric duct will become totally vestigial in case of the females. So the Wolffian duct will not develop once it is confirmed that there is no testosterone and the fetus is going to develop into the female, then the Wolffian system will get suppressed. Mesonephric duct will get suppressed. And then, so in both sexes together, so the mesonephric duct will give rise to the development of the ureteric bud from the caudal part of the mesonephric duct, and a part of the mesonephric duct will be absorbed into the posterior wall of the bladder as the trigone of the bladder. So here the trigone of the bladder, so you know that the bladder interior, when you look at the gross anatomy of the bladder, so we see here the openings of the ureters, both ureters, and then so at the base, so caudally the ureter is opening into it. So the outlet for the ureter is the urethral, or bladder outlet is the urethra. So here the mucosa between these structures will be like a triangle here. So between the two ureters and the bladder outlet, the urethra here, so this forms a triangular region in the posterior part of the posterior wall of the urinary bladder. So this forms the trigone of the bladder. So you know the differences in the muscle of this trigone of the bladder and the rest of the bladder. So the muscle and its nerve supply, these are all little different compared to the other part of the bladder, because this part is developed by the different mesoderm, so which is nothing but the mesoderm of the mesonephric duct, and rest of that is derived from the splanchnopleuric mesoderm. And here it is developed from this part is developed from the intermediate mesoderm, that is the absorption of the mesonephric duct and duct here. And then rest of that, rest of the bladder mucosa is derived from the endoderm, because the urogenital sinus is lined by the endoderm, but initially here this mucous membrane of this trigone of the bladder is derived from the mesonephric duct, so which is derived from the mesoderm. Later the rest of the endoderm will grow onto this region, and that will be this endoderm. So here will replaces the mucosa over the trigone region. Finally, entire mucosa of the bladder is derived from the endoderm only. Initially they thought, so the trigone region, the mucous membrane is derived from the mesoderm, but rest of the bladder is derived from the endoderm. But the concept is changed. So here the endoderm of the urogenital sinus will grow onto the trigone of the bladder, and it will replace completely with the mesoderm here, and it will lead to the development of the mucous membrane of the bladder. But the mesoderm is little different. That is why the detrusor muscle and the muscle at the trigone region is different, right? So because it is derived from the intermediate mesoderm, rest of the musculature and the connective tissue of the urogenital sinus, so it is by the splanchnopleuric mesoderm. Rest of the bladder mucosa, the mesoderm is derived from the splanchnopleuric mesoderm. So that's the fate of the mesonephric duct. So you should remember what is the fate of the mesonephric duct in case of the males, and then in case of the females, and in both. So what are all the derivatives of the mesonephric duct? So now we'll see the development. So we have seen now the development of the mesonephric duct, and so how this mesonephric duct is going into the bladder, how it is absorbed here. So this mesonephric duct will be absorbed into the bladder here. So this part of the urogenital sinus is going to give rise to the development of the bladder. So this mesonephric duct will be absorbed into the bladder till the ureteric bud. So this up to here it will be absorbed here into the urogenital sinus, and later it will give rise to the trigone of the bladder. So if you see both sides, these are the mesonephric ducts which are coming here. These are the mesonephric ducts, which are going into the urogenital sinus here. This is the urogenital sinus here, and so this will be absorbed until we see the, so here these are the ureters here, so ureteric buds. So until the ureteric buds are going into the urogenital sinus. So once this part is absorbed, so this also as the kidneys, so these will be here capped by means of the metanephros here. So this is the metanephros. So this metanephros, initially it is in the pelvic region, that is in the sacral and lower lumbar region. Later this will move upwards. So once the fetus uncurves, so in the early stages the fetus will be curled, so it will be curled like this, so it will be curled. So once the fetus becomes straight, so this there will be room for the abdominal cavity here for other organs to set in. So once it uncurves, so these kidneys will ascend up, and then as these ascend up, these ureterous buds also will be pulled cranially, and these mesonephric ducts will be absorbed here, and this part, this entire part is going to be, this will be absorbed into the trigone of the bladder, so which will form the posterior wall of the bladder. So these mesonephric ducts will move caudally and the ureteric buds will move cranially. That is why the mesonephric ducts, so if you see the adults, so behind the bladder in case of the males, you see the vas difference, and these will be joined by the duct of the seminal vesicles and forms the ejaculatory ducts, and these ejaculatory ducts are opening into the, so here will be the, so here you see the prostate gland here. So these will be opening into this ejaculatory ducts will be opening into the posterior wall of the prostatic part of the urethra. So here it will be opening here. So this is the development of the bladder here. So and then the ureters and mesonephric ducts. And then coming to the metanephric kidney, so we just discussed, so this is the division of the duct system of the ureteric bud, how it goes into comes in contact with the metanephric tissue, and these ducts will divide into number of generations, and each one of these is capped by the metanephric blastema like this, and this metanephric blastema will differentiate into the renal vesicles here. So this metanephric blastema will be in the, so is going to give rise to the cortex of the kidney, where you see the number of nephrons, and also a part of the medulla where you see the nephrons in the medulla. So finally these are going to drain into this is the papilla of the pyramid here, and we can see how these collecting ductules or collecting tubules are opening into the minor calyx. So that's how we see the formation of the metanephric tissue. So finally here so the ureteric bud, the collecting tubules are capped by the metanephric blastema. So this renal tissue, so the metanephric clusters will gives rise to the renal vesicle, which will be giving rise to the nephron. So up to which part of the nephron? It is the DCT, distal convoluted tubule of the nephron. So where these DCT and the collecting tubules will be joined. So if there is any failure of this connection, so if there is no connection or failure of the connection between the collecting tubules and the distal convoluted tubule, so this distal convoluted tubule will be like a blind one, and the collecting tubule will be like a blind one. So this leads to so the urine here it will be secreted, but so this convoluted tubule, so it's not established communication with the collecting tubules, but there is no outlet for this collecting tubules. So here the distal convoluted tubule, this leads to the cyst in the kidney. So this leads to, this is a condition called the polycystic kidneys. So when there is failure of the joining of distal convoluted tubule with the collecting tubules, then that leads to the polycystic kidneys. So there are two types of polycystic kidneys. One is the adult polycystic kidneys, and the another one is the infants polycystic kidney. So in the adults, so it is called the both are genetic abnormalities. So this adult polycystic kidney is inherited by autosomal dominant pattern or inheritance, and the infant polycystic kidneys are by means of the autosomal recessive polycystic kidneys. So two types of polycystic kidneys. So if you see the enlarged kidneys in the fetus and in the infant, then that is the ARPKD, that is the autosomal recessive polycystic kidney disease. This disease will be there, but it will be seen in the adults. So some of these may fail, not all these communication fails, but some nephrons will fail to communicate with this, and this will appear in the adult. So that is called the ADPKD, adult polycystic kidneys is called the autosomal dominant polycystic kidney disease. So you should remember where the defect in the polycystic kidneys. So the defect is in the failure of fusion of the collecting tubules with the distal convoluted tubules. So now where these kidneys are developed, these metanephric kidneys, these metanephric kidneys are developed in the sacral region, the pelvic region. So when these are in the pelvic region, they get their arterial supply from the iliac arteries. As these ascend, so these will be getting their blood supply from the abdominal aorta, and they settle final position in the lumbar region. So these will get blood supply from the aorta here as the lateral branches. So these will get the blood vessels. So as it is ascending, the caudal ones the arteries will disappear due to the advantageous position of these vessels. As the upper ones start establishing, the caudal ones will regress. So as it is ascending, there is no flow that is coming into this. So these blood vessels will regress. So and then finally you see the adult position of the kidney. So till where these will ascend. So here what is the structure? So you know that in adults the kidneys are capped by the suprarenal glands. So that is why their name, adrenal glands are also called the above the renal kidneys, suprarenal glands. Above the kidneys you see these glands, adrenal glands. So these are called the suprarenal glands. So after that there is no further movement of the kidneys, ascent of the kidneys, because they are stopped by the suprarenal glands here. So if there is failure of ascent of these kidneys, so the kidneys may remain in the pelvic region or maybe in the lower lumbar region, or sometimes what happens, one side the kidneys may be absent, or bilateral there may be renal agencies, or sometimes this kidney may cross to the opposite and this may fuse with the other kidney, which is called the crossed renal ectopia. So these are the different abnormalities during the ascent of the kidneys, and sometimes when there is no metanephric blastema formation. So usually this will be associated with the abnormalities of the gonadal system, also the mesonephric duct. So here I told you the mesonephric duct will form the preliminary support to the base for the formation of the metanephric blastema and the ureteric bud from the urinary bladder. So if there is no allantois and no urinary bladder, caudal part of the hindgut is not well developed, then there is no formation of the mesonephric duct, and then sometimes mesonephros may be formed but the bladder will not be formed, and no ureteric bud. So these are the abnormalities which gives rise to to the different various abnormalities of the kidneys as well as the urinary bladder. And here the urinary system is intimately associated with the development of the genital system. So that's why we call it as the urogenital system development. But for the sake of convenience, I have divided this into the urinary system and the genital system separately. So these are the different abnormalities associated with the kidneys. So there may be failure of the ascent of the kidney. So when there is failure of ascent of the kidney, it remains in the pelvic region, then it is called the pelvic kidney. Or sometimes you may see the agencies of the kidney. So this is unilateral agency. Sometimes you see bilateral agency. Here you see both sides, you don't see the kidneys. These are the suprarenal glands. In such case, so the shape of the suprarenal glands will be altered because there is no other structure which is pushing them up. So these will form like a flat structures like this. So I will show you how these suprarenals will look like when there is agencies of the kidneys or any failure of ascent of the kidneys. Or sometimes these kidneys may be going to the opposite side, and that will form the crossed renal ectopia. This is the crossed renal ectopia. Or sometimes you may see two ureteric buds developing from the mesonephric duct on one side, that leads to the double ureter. So here you see two ureters here. So the metanephric blastema also split, and you see the supernumerary kidney like this. So these are the different abnormalities of the kidneys. Once the kidneys ascend, so these will rotate also. So here initially the pelvis of the kidney will be little present posteriorly, but later with the rotation, anterolateral rotation of the kidneys, the pelvis will come to the anteromedial aspect of the developing kidneys. So that's how you see so if there is over rotation of these kidneys, then pelvis will look anterior. So if it is no rotation, then the pelvis will go posterior. So normally the pelvis will be seen along the medial border of the kidneys. So that is because of the abnormalities of the rotation of the kidneys. So these are some of the abnormalities associated with the kidneys. So you can see here, this is the duplication of bladder. So the ureter. So sometimes you may see the ureter. So the ureteric bud may be single one, later it may divide early and gives rise to two ureters. Or sometimes you may see these two ureters may be going directly into the bladder, opening into the bladder directly. Or sometimes what happens, these ureteric buds so may be going into the other structures like the vagina or the urethra or any of these structures. So when there are abnormalities of the formation of the ureteric bud, then we see all these kinds of abnormalities. Then this is an example for the renal agencies, bilateral renal agencies. So we are not seeing any kidneys in this is the fetal abdomen, and you can see here the lying down adrenal sign. So this is the adrenal gland here. So these are not like cup shaped or your triangular shaped or forming caps here. They are just flat structures. Sorry. So here this is the extent of the kidney, the adrenal here. And these are the blood vessels which are coming. This is the psoas major muscle, and there is no kidneys here. So there are no kidneys in this baby. So this is the example for the bilateral renal agencies. When there is bilateral renal agencies, these babies will present with anhydramnios. There won't be any fluid in the fetus. So that's how we can suspect the bilateral renal agencies. And this is an example for the unilateral renal agencies. See here, these are the lobulations of the fetal kidney. This is also a fetus. So in fetus, you see this is another important feature that you see in the fetus. So you see lobulations, fetal lobulations here. So the fetal kidneys will be lobulated, and this is normal. This is a normal finding for the fetus, and here it is malrotated. That means it is the pelvis you are not seeing along the medial border, it is going posteriorly. So there is no rotation of the kidneys here, but it is just ascended. You can see the difference in the adrenal gland shape. So it is capping here in this side because it is pushed by the kidney, but this side there is no kidney at all. This is the psoas major muscle, and you can see the lying down adrenal sign. The adrenal gland is flat. So this is an example for the unilateral renal agencies. Then another condition is called the horseshoe kidney. So here in this horseshoe kidney, what happens? The lower poles of both the kidneys will fuse with each other, and the kidneys, they fail to rotate also. So the ureters will be faced anteriorly. So the hilum of the kidneys will be looked anteriorly, and the lower poles of the kidneys will be fused. See, these horseshoe kidneys will be at a lower level compared to the normal position, because there is an isthmus that is connecting both the kidneys in the midline. So this will not move further up because of the inferior mesenteric artery. This is the inferior mesenteric artery. So this inferior mesenteric artery fails this horseshoe kidney to move further up. That is why they will be at a little lower level, and these people can have a normal life, can lead isolated horseshoe kidney, can lead normal life. These individuals will be normal except for the positional changes here. So here these are the kidneys, the renal vessels here, and you can see the ureters. So on either side, so these are the ureters, little dilated and kinked, and these are draining. So sometimes there may be hydronephrosis in case of the horseshoe kidneys. So this is an example for because it is fetal, so we can see nicely the fetal lobulations also here. So that's the horseshoe kidney. So why the horseshoe kidney fail? It will settle in the lower level compared to the normal individuals, because of the inferior mesenteric artery will prevent the further ascent of the horseshoe kidney. Then this is an example for the crossed renal ectopia. So here this side there is no kidney here. So the right side, the kidney looks like it is absent here. You can see here the lying down adrenal sign and the prominent psoas major muscle. But what happened to this kidney? So it is moved to the opposite side. You can see here how it is fused with the lower pole of the other kidney here. So it is fused with the lower pole of the other kidney, and you can see there is malrotation of the kidneys also. It is anteriorly rotated here, and you can see here the ureter will go to the other side, and then this is the ureter of this kidney, the right side, and these are going into the urinary bladder. This is a female. You can see nicely here the uterus and then the ovaries. This is the fetal abdomen. So you can see this is an example for the crossed renal ectopia. So whenever you see, you don't find a kidney on one side, you should suspect. So when kidney is not in normal position and it is not seen in the renal fossa, then you should suspect so either an absent kidney or a crossed renal ectopia, or sometimes a pelvic kidney. So this is also a crossed renal ectopia. You can see this kidney crossed to the opposite side here and fused with the other kidney. This is also an example for the crossed renal ectopia. And the other one is the polycystic kidneys. I told you, so this baby was submitted for the autopsy after not terminated. This baby is developed fully. After birth, it succumbed immediately after birth, and this baby had huge, they allowed for partial autopsy. They don't want the baby to be done complete autopsy, so only we removed the kidneys. So these are the kidneys, how big they are. Their entire abdomen is filled with the kidneys, and these are the polycystic kidneys. So this is ARPKD, the autosomal recessive kind of polycystic kidneys. This is the cut section of these kidneys. You can see here nicely. So you can see all the cysts here. This is the cortex here. So cortex is filled with the small cysts, all small cysts, and this is the pelvis. So what is the part that is failed here? There is failure of fusion of the collecting ductules with the collecting tubules with the distal convoluted tubule, that leads to the cyst. Nephrons will become cystic, and this will lead to the polycystic kidneys. So this is an example for the ARPKD, autosomal recessive kind of polycystic kidneys. So these babies are not compatible with life. They will die in the childhood itself. And then the other one is the unascended and malrotated kidneys, and then this is a pelvic kidney. So the kidney, if it fails to ascend, so it will be in the pelvic region. So this is a unascended kidney here this side, and it is also malrotated, so it is in the pelvic region. So this side also it is partially in the not completely ascended. You can see when there is failure of ascent of the kidney, you can see here the lying down adrenal signs. So these are not capped by the adrenal gland here. So adrenal glands, their position is fixed. So they are in the upper part of the posterior wall of the abdominal cavity. They no ascent or descent of the adrenal glands. They are not, their position is fixed. Only the kidneys will ascend up and push the adrenals up and form the cap. Over these kidneys, the adrenals will form the cap-like structure. If the kidneys, they fail to ascend, they retain their position and they will not alter their shape, they will look flat. So this is an example for the failed or the ascent of the kidneys and malrotation of the kidneys. So this is a case of urogenital septum malformation defect also. You can see here, this is the rectum and this is the urinary bladder here. So I have opened both the urinary bladder, and these are the ureters which are draining into that hugely dilated, and so this is the bladder and this is the rectum. So the bladder and the rectum both are fused with each other. There is no division of bladder and the rectum in the lower part. So this is an example for the cloacal abnormality or the urorectal septum malformation sequence. So the urinary bladder development, we just discussed how the mesonephric duct is going into the urogenital sinus, how this urogenital sinus, the hindgut is divided into a ventral part urogenital sinus, dorsal part anorectal canal, and how this is absorbed into the urinary bladder. And this urogenital sinus, it is communicated to the allantoic diverticulum here. So this is the allantoic diverticulum into the umbilical cord. Later, this allantois, the proximal part of the allantois will be absorbed into the urogenital sinus and leads to the development of the bladder. But distal part of this allantois will regress, and this will lead to the formation of a remnant of the allantois, which is replaced by a thick cord-like structure which is called the urachus. Just 5 minutes. So this will form the urachus here. So the remnant of this allantois will form the urachus. So this forms and the rest of that allantois partly absorbed into the development of the urinary bladder. And then the distal part of this urogenital sinus will form the pelvic part of the urogenital sinus, which is little narrower, and this leads to the development of the prostatic part of and also the membranous part of the urethra in case of the males, and the membranous part of the urethra in case of the females. But the distal part of the pelvic, this urogenital sinus, definitive urogenital sinus, that we will discuss with the development of the genital system. So but the proximal part here, the pelvic part of the urogenital sinus will gives rise to the membranous part as well as the prostatic part of the urethra. And then, so we discussed again, so the part of the urinary bladder which is developed from the mesonephric duct, that is the trigone of the bladder. So here we see complete formation of the urorectal septum. So where it meets the outlet here, there you see the formation of the perineal body and dividing this into a ventral part urinary system and a dorsal part GIT. Here you see the rectum and anal canal. So this you have seen in the development of the GIT. So that's how we see the development of the ureter and the vas deferens here, and formation of the ejaculatory ducts and the development of the urinary bladder. And then if you remember this urachus now, so this is the urachus here, and this is the urinary bladder here. The distal part of this urachus will get obliterated here, and this will give rise to the development of the median umbilical ligament. It will get obliterated and will be replaced by thick card-like structure connective tissue that leads to the development of the median umbilical ligament. This is the umbilical cord, this is the umbilical vein, and these two are the umbilical arteries. So the umbilical arteries will be on either side of the urinary bladder. So if there is any failure of obliteration of the urachus, this leads to small cyst in the urachus, and these may be or sometimes it may be large, but it will lose its communication with the bladder. Sometimes it may form a fistula. So that means, so completely it may communicate with the bladder like this. You see the fistula, it is called the urinary fistula, through where if it passes, then you see the urine dribbling from the umbilicus here, or sometimes you may see here, so only a sinus here, so only the distal part of the urachus may become penis. So this can be removed surgically. So whenever there are any abnormalities of this can be removed. So this is the urachal fistula. So in urachal fistula, you can diagnosed by the dribbling of urine through the umbilicus. And the cyst, so there is no communication with the bladder, and you see a small cystic structure in the umbilical region. Or sinus, you see discharge. So sometimes if it is infected, it may be the pus. So discharge you see through the umbilicus, then you should suspect the urachal sinus. These things you should differentiate with the vitellointestinal duct remnants also. So there is one more condition called the ectopia vesicae, where the bladder will be, the mucosa of the bladder will be exposed to exterior. So and then when there is severe form where the anterior abdominal wall is not formed properly, and there is defect in the anterior wall of the bladder, and the posterior wall of the bladder is exposed, and the ureters will be exposed. The ureteric openings will be exposed to outside, and this condition is called the ectopia vesicae. And there are other condition called megacystis. So when the bladder is distended with urine, too much urine, and it is this condition is called the megacystis. So when there is obstruction to the outlet of the bladder, so when the bladder is there, so the kidneys will be normally function, they excrete the urine, and the bladder is filling with the urine, but there is no outlet, so the bladder outlet will be obstructed. So it may be especially in case of the males, most common in case of the males, where it is obstructed by means of the posterior urethral valves. So because of that, so the bladder will be obstructed, and it will form the megacystis. So this is an abnormal baby. So here you can see the limb defect also. So the limbs are defective in this case. And you can see I have just removed the bladder with the kidneys. So kidneys are multicystic because the urine is collected in the ureters and it is collected in the kidneys itself. These are multicystic dysplastic kidneys here, and this is an example for the hydronephrosis. Hydronephrosis means dilated ureters. And then so you can see the bladder. This is the urethra, and this is the penile part of the urethra here. This is the male baby. So here it is completely obstructed. The posterior urethral wall totally obliterated the outlet, and the urethra, then the bladder, everything is the distended. So this is ultrasonographically, you see this as a keyhole bladder. So if you see the keyhole, so it will be like this, right? So that is the keyhole. So that is the keyhole bladder. So this is a typical picture for the posterior urethral valves. And then the other condition I told you, the urorectal septum malformation, when there is failure of formation of the urorectal septum. So that there is failure of formation of the abnormalities in the external genitalia. So here there is atresia of the rectum is not opening directly outside. No anal canal. Here you don't see anal orifice. External genitalia are also abnormal in this case, and you can see here when I open the bladder, you can see the opening of the rectum here. So you can see the bladder mucosa is meconium stained. So this is the rectum here. And you can see the ureters, this is the bladder here, and the rectum also opening into the the bladder. So this is an example for the urorectal septum malformation. So when there is failure of formation of the urorectal septum, the cloaca will be persistent. The common cloaca will be there. So cloaca is nothing but the common chamber for the urinary as well as the GIT, that is the gastrointestinal system, and it fails to separate when there is failure of formation of the urorectal septum, that leads to the abnormalities of the urorectal septum. This is one example for the urorectal septum malformation. So these are the abnormalities associated with the development of the urinary system. So next class we will see the development of the reproductive system.